Good afternoon. My name is Char Morrison, and I'm the administrative assistant for today's training program, Evidence-Based Treatment for FASD Roles of Appropriate Treatments in Advocacy. I'd like to go over a few housekeeping rules, and these are general rules. I hope everybody got their handouts today. And if you have any questions or concerns, just generally, after this presentation, feel free to contact us using that email address. So the first thing I'd like to discuss is, before we get started, is no CE credits will be awarded for phone attendance. There is no exception. We cannot tell who you are through a phone number, and that's why you can't be awarded that way. For full attendance, you'll be awarded 3 credit hours. If you exit the session early, your credits will be prorated. Next, in order to receive proper credit from your board's discipline, you have to provide your license number when you register. If you fail to do so, or if you're not sure you did, you provided your license number, again, feel free to send that information to the FASD general email box. After the session ends, you will receive a survey link by email, come in a follow-up email, and we hope you participate, and we'd appreciate your feedback as soon as possible. Everyone should receive a participation certificate within 7 business days. If that doesn't happen, and you don't receive, again, feel free to email us at that FASD general email box. Lastly, all participants will stay muted so that we ask that you enter all your questions during the presentation in the questions platform box. And so what will happen is periodically, someone will answer those questions for you. Again, if you have any questions, please feel free to put them in the question box, and we will periodically stop, read the questions to Dr. Ergen, and hopefully we get everything answered at that time. So next up is the FASD Program Manager, Karen.
Good afternoon, everyone, and welcome to the 3rd FASD session in a series of 5, entitled Evidence-Based Treatments for Fetal Alcohol Spectrum Disorders, Role of Appropriate Treatments and Advocacy, sponsored by the Ohio FASD Steering Committee. My name is Karen Kimbrough, and I am the committee chair. At the end of this session, participants will be able to identify the evidence-based treatments for FASD. Participants will be able to gain knowledge about how to best advocate for a client or individual with FASD within various systems. Participants will be able to gain knowledge about various resources regarding diagnosis, treatment, organizations, books, websites, and parent groups. We review your comments at the end of each session, the ones you put on the evaluations. And one of the comments that we are able to address in this training is we're going to include a small break halfway through the training. We appreciate your feedback. We value your feedback. And at this time, I will introduce Alexis Martin, who will introduce the presenter of this training. Thank you and have a nice session.
Hello, I'm Alexis Martin from the Ohio Department of Health, and I'm the co-chair on the State Steering Committee. Now I'd like to introduce Dr. Ergen. She's an associate professor and licensed clinical psychologist at the School of Professional Psychology at Wright State University. Her teaching interests are cognitive assessment, child assessment, and clinical neuropsychology. Clinical interests include infant and toddler assessment, pediatric neuropsychological assessment, psychoeducational assessment, school psychology, school consultation, treatment of externalizing and internalizing disorders of childhood, parent training assessment, and treatment of developmental disabilities, autism spectrum, and fetal alcohol spectrum disorder, and prenatal drug and alcohol exposure. Dr. Ergen is an active member of the Ohio FASD Steering Committee and conducts trainings, workshops, and presentations in Ohio regarding prevention, diagnosis, treatment, and advocacy of fetal alcohol spectrum disorders. She's also a member of the American Psychological Association and National Association of School Psychologists. So without further ado, I will hand it over to Dr. Ergen.
Thank you very much, Karen and Alexis, for the introduction. And today, I'm very happy to start our third webinar in the series regarding talking about evidence-based treatments for fetal alcohol spectrum disorders. So first of all, I wanted to, I did not specifically include with an introduction for fetal alcohol spectrum disorder. I'm just hoping that some of you have also participated in my previous series and webinars regarding what fetal alcohol spectrum disorders are, how can we screen for, how can we diagnose, what are the symptoms, and what are the red flags. So I have talked extensively about those in the prior two webinars. But all in all, for those of you maybe who did not have a chance to participate in those webinars, fetal alcohol spectrum disorders is a neurodevelopmental disorder that is caused specifically by prenatal alcohol exposure. If there is no prenatal alcohol exposure, there is no FASD. FASD, as opposed to not being as known as much, the prevalence is quite high. It's 2 to 5% in US and in different parts of the world. It is the #1 preventable neurodevelopmental disorder and cause of intellectual disability. So having said that, prior we have talked about the symptoms and ways to diagnose, which of course all of that diagnostic and screening process is in the hopes that there is going to be a treatment to help the clients and their families. So today I'd like to focus very specifically on the evidence-based treatments or other treatments that have been piloted. What are some ways to advocate during this treatment process, and what are some ways that all of us in our own practices, whether we have a chance to follow the evidence-based practices, whether we got training in them, but how can we at least integrate some of these elements into our day-to-day interventions as we are working with children, teens, and adults and their families with FASD. So that's kind of like my goal today, to inform you about the interventions and the treatments. And as I go through and explain them, I will be also talking about what are some of the areas that still need research, what are some of the areas that we need to focus on, how can we advocate for our clients, or if you are a caregiver, how can you advocate for your own child or for your loved ones. And I will make sure to integrate that into the entire presentation rather than talking about it as a separate topic. So first of all, what I wanted to start out with is what does research show in terms of what are some of the variables that we need to consider in treatment? Who has better prognosis? Who benefits more from the treatment? Who is left behind? Because that's a very important question. So to be able to understand that, I'm going to talk a little bit about Paley, who in 2009 listed and looked at some of these variables in the treatment. So first of all, we will do a good diagnostic evaluation. As a result of this diagnostic evaluation, which is going to be a thorough one, we will determine areas of focus in treatment because not one individual with FASD is the same as the other, because as we know, FASD is on a spectrum. And individuals, they have highly variable presentations. Some of them have lower IQ, some of them have average IQ, and some of them have high average to superior IQ. And they also have different symptomatology depending on the timing of exposure, amount of exposure, and other psychosocial variables. So what research indicates is that, and I know that some of you will appreciate this, maybe having gone through the diagnostic process for your own children or loved ones. A child who is an IQ more than 70. And what is an IQ more than 70? That means that the child does not have intellectual disability, okay? or if the child has a diagnosis of alcohol-related neurodevelopmental disorders, or a partial FAS, meaning that if the child does not have the full-blown fetal alcohol spectrum syndrome disorder, and then if they do not have intellectual disability, it means that they will probably have more negative treatment outcomes. And you might say, like, why is that the case? Because they do not have intellectual disability, which is great that they do not have to work with that piece, or they do not have a more severe form of FASD. Well, that's actually the opposite when it comes to FASD. Individuals who have IQs that are high and individuals who do not have the severe presentation of FAS, they have a less chance of being identified, okay? And they have less chances to qualify for services, because if an individual has ID, they would qualify for DD services, right? So therefore, this category of individuals will be at more risk for dropout, not having access to services, not qualifying to services, would engage in more delinquent behavior, would engage in drug abuse, and therefore will experience more of the secondary disabilities. And why did I say all that? Well, the reason is that all our interventions that I'm going to be talking about today, they need to target the entire spectrum and not just focus on children who have fetal alcohol syndrome, which is the more severe form of the FASD. Okay? Therefore, if you are designing interventions, if you are implementing interventions, we have to make sure that it targets the entire spectrum. Therefore, we do not want our children who are on the milder end of the spectrum not fall through the cracks. And I have no doubts, maybe I'll hear it in the questions. If we were live face-to-face, I would have said, how many of you had that happen to you? Like your child did not have the severe form and you have tremendous difficulty with getting a diagnosis and getting appropriate treatments. And that's why I wanted to open up this webinar, really emphasizing that piece, that we have to be really inclusive in our interventions. Another very important piece is that interventions need to include not just children. Our more traditional interventions, intervention for depression, anxiety, we would more, as psychologists or counselors, we would work with the child and we would implement the intervention with the child, and we would check in with the parent. Well, FASD is not a disorder like that. FASD interventions need to include children, specifically their parents, and I'll talk so much about that one, their foster parents and adoptive parents. So whoever is whether the biological parent, foster parent, or adoptive parent, but they need to include the whole family system. And another piece is that the interventions definitely need to build on support for the family, psychoeducation to the family, and giving them both knowledge and skills at the same time. So if just a pure psychoeducation would not be enough. So we have to provide things like behavioral management, parenting skills, how to deal with parental stress, okay? And then working with the parents. This is a part that's really important. So if you come to our last presentation in our series, where I'll be talking about stigma and FASD, this is a really important part that we need to work with both biological parents and adoptive parents or foster parents regarding how to deal with stigma with the child and with their within their family and community system. Also, good interventions will also need to focus on ongoing substance use in the family, not just for the biological mother, but just like if the child has access to other family members who continue to use, those will have a dire impact on the prognosis when it comes to treatment. So therefore, what we could say is that the most effective interventions for FASD need to have these following components: behavioral management protocol to deal with the disruptive behaviors, aggressive behaviors, behavioral dysregulation. There has to be a component for parenting skills where there is explicit instruction, working with the parents one-on-one on improving their parenting skills, while at the same time increasing their confidence and their ability as to how they will cope with raising a child with FASD. And a good treatment also needs to include information about stigma, as I mentioned before, information on substance use, and first of all, aim to, of course, decrease the primary symptoms. The primary symptoms are behavioral regulation issues, emotional regulation issues, increasing adaptive skills, and dealing with difficulties with learning, memory, and maybe sometimes like motor skills or sensory skills. But then we do not just have primary symptoms. We also have secondary symptoms. So it also should deal with the secondary symptoms. And to do that, we have to make sure that we provide a lot of wraparound resources, services, education, training, and direct services to the caregivers. So I cannot really emphasize this enough as to how valuable, how important, and how effective it is to include caregivers in the treatment of individuals with FASD. And finally, effective interventions do provide do maximize adjustment of the family. Adjustment meaning that when a family gets a diagnosis about their child, whether that's autism, ADHD, FASD, that's an adjustment process, and it's a new identity. So we have to make sure that we have some nice conversations about this adjustment and making sure that parents feel equipped to start this journey, which is a beautiful journey, and therefore help them to decrease the parenting stress. So not to downplay all the stress and the difficulties that will come with that. So therefore, keeping that in mind at the beginning, that there is going to be parental stress, and a good intervention has to make sure that they also address those parts. Couple other things before I move on to my next slide that I still wanted to mention is that, remember I mentioned about psychoeducation. So when we provide psychoeducation to the parents, what are some of the things that we need to include? Some of the things that we need to include is information about the nature of the disability. We have to explain the brain, the relationship between the brain and the behavior. So how does it work? What are the brain areas that are impacted? And after that, how will it manifest? How will it show itself in the daily life? Well, okay, we can say the brain area of memory is impacted. Well, what does that mean? What does that mean in daily life? So giving examples of, so this means that in daily life, when you give instructions and they're complex, they have 3 things in it. Well, maybe it'll be very hard for your child to understand all of them at the same time. So as a result of that, it will be helpful to give 1 instruction at a time and keep the instructions short. So this type of psychoeducation is going to help out with understanding the complexity of the situation, and then help the families to what I call reconceptualize, which means that reimagine what the life is going to be like with their children, so that they can keep on being supportive, so that they are more patient, so that they do not think that they're failures as parents, that they do not think that they're bad parents. A lot of the times these are things that we hear, and these affirmations, which are not positive, definitely impacts the treatment outcomes. Okay, and a good intervention, when we provide the psychoeducation, also puts down goals for intervention. We cannot start a treatment program without having goals in our mind. Okay, and we have to make sure that we should be flexible as clinicians and providers to revise those goals. I have seen a lot of failed treatments, and the reason was that the provider was kind of stuck and they weren't willing to try other things. But let me share with you, it's very important to start out with a treatment plan. And if it doesn't work out, it is completely okay to try something else, because our children's brains are also plastic, meaning that it's developing, it's still evolving. So what could work one day might not work the other day. So we have to keep also trying and not give up. That's very important. And then the last piece under the education piece is we have to keep the conversations open regarding how to effectively advocate and how to teach the parents advocate for their children. Okay. This is very, very important, because in a lot of the systems that you as parents or providers will interact with, the doctors, the psychiatrist, the school, the legal system, the social welfare system, we should know that many of the professionals working in these areas will lack the training to identify and treat and advocate for individuals with FASD. So I would say that you as parents or providers would be in a much better position to advocate for your own child. So it's our role as clinicians or providers to teach the families as to how to advocate for their children as they navigate the treatment piece in their lives. So I would like to start talking about some of the more evidence-based randomized trials, meaning that these intervention methods or models have been tested out, piloted, and where they provided an experimental group, which is the treatment group, where some children received these treatments that I'll talk about, and then the other half received, which we call a control group. They received either no treatment, or they just received, usually, it's not ethical to provide no treatment, so it's usually kind of like a psychoeducation group or a support group. Okay, so and these have been scientifically validated to be utilized. All right. But then, again, if we were more face-to-face and could be more interactive, I would have asked a question. How many of you have heard of these treatments? How many of you are familiar with these treatments? How many of you had the chance to be trained to use these treatments? How many of you have read about these treatments in a website or in a book, or have heard about it maybe in a parent support group? Again, not getting the specific answers, but I would presume that maybe not a lot of you have heard all of these readily. Maybe you've heard about Pcit because it's not specific to FASD. It has been just utilized for FASD, which I'll talk about. However, these programs, first of all, have been utilized in certain clinics or settings as being piloted. However, the downside is that they have not been integrated into our regular community mental health, where individuals can get these treatments readily. So that's why at this point, we have a little bit of a difficulty, and I'll talk about some of the limitations of these programs. But all in all, it's helpful to gain some information about each of these programs. And I also added some more programs and more interventions that the literature shows us right now. So I'll be sharing each one of these. So what are the elements of these interventions? So it's pretty similar to what I kind of talked about, but more specifically, it gives us a little bit more information. So why are these 5 selected, and why do they show good evidence? They show effectiveness and a good evidence to help out individuals with FASD and their families because of these factors, that the ones are on the left, which are the elements of these interventions. These interventions all included parent training, meaning that there was some kind of behavioral management system that was taught specifically to the parents, paired with psychoeducation. So then, even if you're not doing any of these, evidence-based or randomized, interventions, it is very important that you can provide a behavioral management program along with psychoeducation about FASD to your families that you're working with, okay? Another great element of these interventions is that they provided what we call explicit instruction. So a lot of the times when we work with parents on or with children on other modalities or other disorders, we use more, we talk about it and then we observe, we use more observation, modeling, but we do not explicitly teach all of the skills, unless it's more for something like maybe autism, like an ABA, okay, where there is more explicit instruction. But all in all of these programs have used explicit instruction as their mode of teaching. So what that means is that they taught the skill, they showed the skill in the session, they asked the parents to do it in the session, and they provided specific feedback as to how the parents are actually doing. In our more traditional therapies or counseling methods, we talk with the parents. We say that, well, this week you can try timeout. And here is a handout, and this is how you can do. And this is your homework. So they go home, they try it, and then come back. And then they give you feedback as to whether it worked or not. So as opposed to that traditional model, okay, then parents in these randomized trials, they have been given this explicit instruction, and they had a lot of chances to rehearse, get corrective feedback, and then implement it again, along with, of course, homework. So that's why when we hear that children with FASD do not benefit from traditional parenting practices, they do not benefit from traditional counseling or therapy methods. That's probably why, okay? And another great benefit that these intervention models have provided was using the already out there community resources. When we think about FASD, we think about a village. And I'm sure a lot of you have already figured that out. A child with FASD will require early intervention services, speech, OT, maybe PT, individual therapy, working with a psychiatrist, maybe for medication management, casework, and then advocacy within the schools. So these programs really use the community services that are already in place in the community, such as working with the schools, working with the physical therapist, working with the therapist who's already seeing their children. So not add extra work or extra effort on the families who are already tasked with trying to do their best to take care of a child with FASD. And then the last element of these interventions is making sure to include parents as agents of change. Well, what does that mean? Parents as the safe person, as the person who is always there for the child, and the one who will be almost that external brain of the child to learn skills and to practice skills, and while doing that, feeling safe at the same time. So that's why integrating parents into the treatment modalities, whether you use any of these interventions or you use your own parenting techniques and so forth, making sure that parents are integral part of that treatment. And because of all of these elements that they found out, that these 5 randomized trials, ended up with these 5 intervention, models and treatments that were effective in reducing the primary disability and some of the secondary disabilities as we work with children and teens with FASD. But then, of course, we know that there are also some limitations of these interventions. What are these limitations? The limitations are that there is really not good long-term follow-up. So some of these interventions looked at, okay, well, it works now, right after the intervention. Well, do they get generalized? Are they still experiencing the benefits after 3 months, 6 months, 9 months? What about in a year? Or have they all forgotten about those? So some of these have done follow-up, and when I talk about each, I will mention each of those data. But some of them did a follow-up for 3 months, some of them did a follow-up for 6 months. So some of the effects and the benefits were carried out in time, which is great. But today, till to this day, we still do not have a good follow-up for like 1 year, 3 year, 5 year. For example, let's think about any other treatment modality. Maybe some of you are familiar with the coping cat. That's a evidence-based treatment to reduce anxiety symptoms and to increase coping symptoms in children with anxiety disorders. Well, that one has a lot of studies on how it fares in after 1 year, 3 years, it even holds up, in 5 years and so forth. So we still do not have that. We're still, I think, at that infancy stage for looking at the effectiveness of different treatment modalities for FASD. So I also wanted to share that piece. Another problem with this research is also that, as you will see, when I explain each of the models, you'll hear me saying, well, the sample size was 20 children, the sample size was 40 children. Again, accessing children with FASD and then have them agree to research is also not an easy thing. And you would appreciate why. Probably some of you are parents or caregivers. You are already tasked with so many different therapies or interventions that you need to go to and take your child to. And the last thing on your mind is probably being part of a research study. But that's extremely important because only along with research that we can also advance in this field. And then the last piece is lack of generalization data, which means that we know that the skill that we're trying to measure, which is, let's say, better attentional skills, okay? They can do it now. Well, can they generalize that skill to school? We do not have evidence for that. So unfortunately, again, that's another area that that a lot of these studies really need to start to work on. So I will now start talking about the different types of treatments. And before that, I would like to maybe get some questions, if there are any so far, about some of the things that I've been starting to talk.
So far, Dr. Ergin, we don't have any questions in the question section, so.
Okay. All right, very good. Just like to check in every, 20 minutes or so.
Absolutely.
Thank you, Karen. So in terms of treatments, and I put this, graph in there too, just to understand, and I'm not going to go into all of these because I talked very extensively in my previous, webinars about the impact of alcohol on the brain. But as you can see, for those of you who may not be as familiar, alcohol impacts several parts of the brain, including attention, IQ, language, memory skills, emotional regulation, behavioral regulation, executive functioning skills, school achievement, and adaptive skills and motor skills. Well, those are a lot, right? Then you can say, oh, Dr. Ergin, which area do we start out with? What do we do? Where do we get started? So let's talk about each of these areas. So how I kind of put all those together is I'm going to be talking about some educational treatments, but I won't go into detail too much because, again, as I said, our next webinar is all about education and what to do in the schools and some of those educational treatments. Then I'll be mentioning some of the cognitive treatments, parenting treatments, behavioral consultation, social skills training, safety training, case management, some medical, pharmacological, approaches, and specifically more medication management. So I wanted to start out with the behavioral consultation piece, and one treatment that has a lot of great data and research base is families moving forward. This was developed in the University of Washington at Seattle, and to this day, you know, everyone, if they pay the fee, they can go and have training on this model, and they can actually bring it to their own organizations after having been trained on that, and they can start engaging in that process of training other people. Of course, that requires some extensive training on their part to be able to do that, but that's possible. So Families Moving Forward is a behavioral consultation program that is tailored for families who are raising children with FASD. So when it first started and piloted, it was for the age ranges of 5 to 11. Now it covers the age ranges. It's been expanded more with more research with ages 3 to 13. So this is a pretty good, you know, age range. Initially, it was tested with 52 families. So as you can see, it's not a whole lot. And they conducted 16 sessions, and they were all in-home sessions for a period of 9 to 11 months. Okay, so after that, now how it looks like right now is that they expanded it to also clinic sessions, not just home, and you can have between 14 to 16 sessions. It runs from a span of 6 to 11 months, around that, and each of the sessions now can be 60 or 90-minute sessions. Okay, so what does this program do, and how do they do that? Well, first of all, the goal. What is the goal of this session, of this intervention model? The goal is to enhance parental self-efficacy. So we want the parents to feel that they can do this. I can parent my child. I can help my child, versus having all these feelings like, no, I can't deal with this. This is too hard. I can't. So a lot of those coping skills, self-efficacy skills, are very important, because we do see some foster parents who feel that they failed, and they say that I cannot do this anymore. And unfortunately, some of our children who need a stable home have to stop with that foster family, and they need to go back to the system in the hopes of getting another foster family and ultimately adoption. But that's very disruptive to the already compromised brain of a child with FASD. Therefore, any treatment that would target that self-efficacy and sense of coping is very, very helpful. And that's why this program is really successful. So that's one, enhance self-efficacy. The other goal is to decrease, of course, child's problem behaviors. Why are parents stressed? And again, I would have, loved to get some thoughts from some of the parents in our audience, because there are a lot of disruptive behavioral problems, right? There is aggression, there are tantrums, there are meltdowns, there is destroying property. So a lot of those are disruptive behaviors. So another goal, of course, is to decrease those behaviors. So how do they do that? So parents are taught specifically to use what we call antecedent-based behavioral strategies. So what does that mean? It means that you learn why your child might be acting out. Why are they non-compliant? Okay. What are your child's triggers? What is the function of your child's behaviors? What does that behavior serve? Can you understand that? Do you know each time? Then you might say, like, well, we can ask the child. The child would not know. The child cannot tell, because they are not aware, because their system is dysregulated. And if the parents don't know, the child doesn't know, the combination of that is not good. Parents start to get more defensive when they have a child who argues with them, fights with them, and then we do not have a good outcome. Okay? So parents are taught to learn the triggers and the function behind the behaviors of their children. And as a result of that, what do they do with that information? They're also taught to make adjustments in the physical environment of the child to optimize the functioning of their children. So what that means is that we are not trying to change the child, because we know that there are some things that we cannot change due to this disorder being more brain-based. Therefore, we try to understand the child, acknowledge where they're coming from, trying to replace those behaviors, and then we try to change the environment based on that information. Okay? So how do they do that? What are their methods? Their methods are coaching, providing direct support, and then decreasing the parent's negative self-talk, which is, no, I can't do this, saying, no, you can't do this. Let's try once again. Okay? So through these, they worked one-on-one with the parents, both at home and sometimes in the clinic. Another wonderful thing that this program does is providing school with focused consultation. So there is a clinician in the team of Families Moving Forward who consults on behalf of the parent and in conjunction with the parent, okay, and then teaches them advocacy skills as to how the school should handle the child with FASD. A lot of the times, parents are very much annoyed, bothered, and worried about what happens in the school for their child with FASD. Okay, therefore, providing them with this resource is definitely wonderful and a great support and a great relief on the side of the parent. And the third thing is they also link the families with community services. While trying to take care of a child with FASD who already has a lot of disruptive difficulties and trying to deal with school, then you have all the piece about how am I going to have access to these services? Where am I going to find this therapist? It's extremely hard to make all of this happen, and our families do need help. So having someone to connect them to the resources in the community is extremely helpful. Okay. So all in all, what did the results show? So the results show that there is significant improvement in the self-efficacy of the parents, which is a wonderful thing. After the treatment, they feel like they can cope with this. They do not talk negatively to themselves that they're bad parents. They understand their child more. They can make modifications in their children's environment. They know their children's triggers, and they know how to regulate their children. Okay. However, we had one limitation, which is there was some decrease in the problem behaviors, but not all of it. So what does this tell us? It tells us that this program is really helpful to target the parents who are really struggling to deal and help their children. However, at the end, some of the behaviors might need some more focused behavioral interventions. Okay, so that's kind of like the gist of this piece. All right, well, having talked about focused interventions for behavioral issues, okay, so we can have the families moving forward, and then we can take care of our parents, which is wonderful. And now they feel like they can do this. Now, what can we do to decrease the problem behaviors? Let's talk about that. Pcit, and I'm sure some of you have heard that, use it successfully with your children who have oppositional defiant disorder, who have conduct issues, who have disruptive behaviors. So this has been modified to use with children with FASD. The age range that they tested out this was 3 to 7, and they did 14 weeks, 90-minute sessions, okay? So, and then they compared this with another program called the Parenting Support and Management, which was a only parent education program, okay, to see like what's the difference between these two models. So with our own model with the Pcit, the clinician, the therapist, work with the parent and the child together, okay? And they provided a lot of behavioral management strategies in the session. When there is a bug in the ear where they have something in their ear where they are put in front of the one-way mirror, and they are instructed to engage in certain behaviors, such as Now, please praise your child. And the child says, does something the parent praises. Now, please try to describe what the child is doing. And then the parent goes and does it. And then the therapist gives feedback, continuous feedback to the parent. So this really increases the confidence of the parent. How many of you, if you have already worked with your other children for counseling, or if you're a parent yourself, somebody gave you a recommendation, and you come home and you go like, how do I do this? I'm not really sure. But these parents, because they get the actual practice in the session, when they go home, they know exactly what to do because they can replicate what they did in the session because they got what we call in vivo coaching about how to handle problem behaviors. Okay, so feedback is provided to the families at the end of each session saying, well, I really liked today how you were able to describe and be present with your child. I really liked how you were able to set limits, okay? And then, of course, they're given homework to reinforce these skills. So what they found was that both of the groups showed decreases in parental stress and child problems. However, the Pcit group showed greater reduction in the stress of the parent, their self-efficacy, as well as in their behavioral problems, reduction in the behavioral problems. So what this tells us is that Pcit really focuses on that relationship, parent-child interaction, which is very important because a lot of our children with FASD come in with a lot of trauma. I'm not just talking about the prenatal trauma, but it's the postnatal trauma that they probably have experienced due to neglect, physical abuse, sexual abuse, frequent change of homes, and not having enough resources and so forth. So sometimes when they come in with the at the adoption piece, then they are already they have insecure attachments. So Pcit would address the issues around attachment, would work to increase that bond, and at the same time, because it's very behavioral oriented, it will help to decrease behavioral problems. Okay, so Pcit is readily available in many places, in clinics and so forth. So if you have a child and you don't know how to do Pcit, you can easily refer them to get Pcit, and if their child is younger. So it works much better with our younger children. Unfortunately, it doesn't work as well with the older children because when they get into their teens, they don't respond well as to some of those behavioral strategies as much. So it's helpful to start early on. All right, so we mentioned that before, like children with FASD, and I again talked extensively on this in the previous webinars, that children with FASD have a lot of difficulties in the social arena. They have hard time understanding social cues. They have hard time figuring out who is a stranger, who is a friend, who is an acquaintance. They don't have the stranger danger. They could go on and sit in a stranger's lap sometimes. They could put themselves into danger without knowing. They could be overly friendly. They could be very easy to persuade and be taken disadvantage of. So as a result of that, these specific social skill deficits have to be targeted in treatment. Okay, so to address this, then O'Connor in 2006 came out with what we call Children's Friendship Training, CFT. This is one of the other evidence-based models where it's a manualized treatment, first of all, and it's a parent-assisted social skills intervention. So to teach the social skills to children, and what are some of the things that they focused on? They focused on play date skills. What do you do in a play date? How do you play with your friend? Okay, play entry, which is how do you enter a group? What do you say? So like very explicit instructions. What is acceptance? What is rejection? Unfortunately, our kids with FASD experience a lot of bullying, and therefore it's really important to talk about being accepted, being rejected, very specifically. How do you give feedback to each other? What do you say each other? Those are very important things in our social skills and in making friends. Okay, so these skills were taught via instruction on simple rules of social behavior, and they use modeling, they use rehearsal, which is practicing over and over again, performance feedback, which is telling them how they're doing. Okay, and then they also gave homework to do at home, which we call rehearsal at home. And when they also set some scenarios in the session where the parent has a chance to rehearse in the session, and then the clinician would give feedback saying that that's good, you're doing really well, let's change this. Okay, so they tried this with 100 children, so this is good. We have a better sample size here, and the age range that this is helpful is 6 to 12. Okay, so that's that school age child age. They tried it for 12 weeks. So as you can see, none of these interventions are short, and it just takes time because the brain also takes time to learn because of the compromise areas. And they did it for 90 minutes each session. And what are our results? The results show that there was an increase in our treatment group in the knowledge of social behaviors. So when you ask children the questions, what are you supposed to do when, and then they were able to answer these questions much better than before the intervention. Also, parents rated their children in terms of their social skills before the intervention and after the intervention. So after the intervention, children with FASD, they were found and rated by their parents to have better and higher social skills. And they also exhibited fewer behavioral problems. So it not only increased social skills, it also decreased behavioral problems. And the nice part, which I mentioned before, is they did a study to see if it held up over time. And they did a study for after 3 months, and they found out that the gains and the benefit that they had really held up after 3 months after the intervention. So all in all, I would say is that even if you may not have access to these specific treatments, just know that if you have any type of social skill intervention, okay, if you're going to be using that in integrating parents into it, where you give coaching, rehearsal, explicit instruction, okay, and then homework, it's going to be helpful. You can utilize social skills training and those groups with your children with FASD, even though it's not specifically maybe the CFD training and those elements, because I could hear some of you saying like, we do not have access to these specific trainings or the specific interventions in terms of like a manual and so forth. And unfortunately, they are not readily available everywhere. Like Coping Cat, you can go on and you can buy that. But that's not the case for our FASD treatments. And however, the goal of my presentation today is to inform you of these interventions that are out there for those of you who'd like to maybe go and sign up and be trained. But if you can't, what I'd like to convey to you is that each of these elements can be integrated into your treatment, and the children will definitely benefit from it because those are the areas that they definitely struggle in. So in terms of safety skills, you might say, why are we worrying about safety? There are so many other things that our children are having difficulties with. Well, this is extremely important. Children with FASD have less awareness for safety issues. They tend to, again, inadvertently, they tend to put themselves into dangerous situations because they have a hard time understanding cause and effect. If I put my hand on the stove, it will burn. Well, they get burned, come again a month after, they could engage in that same behavior again. So it takes them longer amount of time and longer trials, which can be painful, right? And they can hurt themselves and others for them to learn. They do learn at the end, it just takes longer time. Therefore, teaching them safety skills is very important. So Coles in 2007 developed a safety skill training. It's a computer-based intervention, which again, I have not been able to, have access to it, but from all the descriptions, it looks really, really fun. So two areas are covered. One is what to do when you have a fire at home, and how can you be safe in the streets, like with traffic, with walking and things like that. So fire and street safety skills in 32 children. Again, as you can see, the sample size is low, and ages 4 to 10, again, younger ages. The method that was used was that they use a computer game, and the computer game was interactive. So they put out some scenarios, and then they asked questions, and then they had options to choose. What would you do if you started, smelling something as smoke at your home? And then they had all these options, and until children gave the correct responses, then they couldn't pass that module, or they couldn't pass that piece, okay? So because it has visual piece, it's interactive, it's interesting, it held up the interest of the children, and it also provided instruction regarding safety, because first it teaches that, and then it tests out the skills, okay? So what they found was that it improved their safety-related knowledge and their behavioral responses. So they not only learned about the safety issues around maybe playing with the matches, but they also learned what to do. So not just the knowledge, but the responses. What to do if you smell something or if you see a flame in the house. So they also learned about those behavioral responses, which can be pretty hard for some of the children with FAST to learn and make that association, okay? And another good thing is that they were able to generalize it to real world situations later on. So I think, again, you might say, well, we do not have this computerized program readily available. What about social stories? I think we can all make social stories, and you can come up with your own social story using animals. And we can integrate different situations that your child, your client is struggling with, maybe being safe at home around the stove or things that are electrical. And you can create that story, maybe on paper, and then you can walk them through, give them the instruction, and then have them practice on those pieces. Sometimes safety skills don't get at the forefront. However, they have dire consequences. I have seen some children trying to jump up off the roof and hurt themselves because they thought they wouldn't hurt themselves. It wasn't as much of a big deal because it wasn't too, too high. Or I have had some kids go down the rail of at school from the 3rd floor to 2nd floor and then fall and hurt themselves. So all in all, if they do not have this type of safety training, they could put themselves into danger, they could put others into danger, of course, without knowing and not willingly. However, those do happen, and then they do have consequences as a result of that. So to prevent that, please make sure that in any way that you can, including safety skills in your general treatment protocols. Again, looking at the watch at 2, I wanted to see if there were questions that I can address before I maybe move on to some of the educational interventions.
Okay, let me open up the question box again. We have 3 questions, Dr. Ergin. The first question is, are siblings included in any of the treatment modalities?
That's a wonderful question. Unfortunately, siblings are not included. And then, I could ask the question in my mind too, like as to, why not? I think, first of all, they would want the parents who are the more stable adults, because siblings could also be in the same position as our client. If they are biological siblings and they have been adopted into the system, they might be also struggling with the same, piece. Obviously, it would be good to integrate them as doing a group maybe. But at this point, all the treatments included the caregiver / parent, whether that's a biological parent, foster parent, or adoptive parent. But a lot of the skills that the parents are learning through these programs, they can also utilize with the other siblings who might be struggling in different ways or same ways.
And that question came from Susie Tupper.
Mm-hmm. Thank you.
Next question is there, wow, just a second. Okay. Give me a second to get back in there. Is there an age range? We know you said that the Pcit works best with younger children, but the question coming from Ariana Brooks is there an age range for this Pcit?
Yes, I might have missed that, but I think I might have mentioned as well, the age range for Pcit that's found to be effective is 3 to 7. So after that, if you can recall, the effectiveness kind of goes down because it's a very specific behavioral and more relationship-based program. And after our children are, 8, 9, and kind of like going into that, age range, they do not only respond to behavioral interventions. So we have to have other things in place. So the best time is when it's early, 3 to 7. And again, if at that age we can just nip some of those disruptive problems, then it works the best.
And she also asked the same question for CFT as well regarding the age range.
Okay, let me go back to that. Look at my notes for that one as well, just to make sure that I do not give a wrong response. Okay, the CFT's age range is 6 to 12. That it's effective, 6 to 12.
Okay. She said thank you. The next, just answer it in the box. It's not about the training exactly.
Okay.
That's it for the questions. Thank you, Dr. Irvin.
Thank you. All right, the next area that I'd like to talk about is educational interventions. So first of all, children with FASD, as I've talked about before, they have significant difficulties in the area of learning. They have hard time learning big chunks of information. They have hard time keeping the information in their mind, and they have hard time consolidating that information so that they can remember it later. They also have pronounced difficulties in learning math, abstraction, learning to do, story problems, math reasoning, learning to tell time, learning about money. So anything that's abstract, and math is very abstract, is extremely difficult due to the impact of the alcohol on the prefrontal cortex, which kind of like houses these functions around problem solving and abstraction. As a result of that, our children with FASD, their difficulties interfere a lot with academic functioning. So we see a lot of comorbidity with specific learning disabilities. So as a result of that, teachers and most of the time they find themselves in positions where they need to provide different ways to teach children, and parents find themselves in situations where they need to help their children learn in a different way. So therefore, they do need a lot of support themselves, okay? External supports are needed to help both the teachers who might be unprepared to work with children with FASD, and then to parents who are trying to advocate for their children to get accommodations, to get special education interventions, to have an IEP at school, and then to make sure that their children are effectively educated within the school system so that they are not put at a disadvantage due to their primary disabilities. Okay, so in that realm, what are some of the helpful training teaching strategies? So helpful teaching strategies within the education system is, first of all, for a teacher, and these are some things that the parents can advocate for in the school so that they actually implement these for their children. One is implementing consistent, predictable routines, okay? Well, all children have a routine at school, but sometimes things might change. Well, that wouldn't go well for our child with FASD. So consistent, predictable routines. Two, scheduling activities in the same order. Similar to a child with ASD, a child with FASD would want to have that similarity in consistency in their schedule. And this would lead to less likelihood of having meltdowns or temper tantrums. Also, both parents at home when they're working, studying with their children, or teachers at school, they need to provide opportunities for rehearsal. Rehearsal is extremely important. I cannot emphasize you the importance of that. Rehearsal will increase memory skills because children with FASD, their hippocampal area is impacted through the impact of alcohol, which means that they have significant memory difficulties. They may forget what they have learned the next day or the other. Therefore, with the impact of rehearsal, it will help them to learn, overlearn, and then it will help them to recall and remember the information later on. So lots of practice, lots of rehearsal is the key. They also have to make the contingencies explicit. What does that mean? Our children with FASD, they have a lot of difficulties with knowing what causes this and what's the effect. Oh, if I do this at school, if I just get up and go, well, I'll disrupt the class and I'll get into trouble. Just combining these two things is really hard. Well, a student, a typical student coming into the classroom will probably figure that out pretty easily, because the teacher will say, well, you'll lose this privilege if you just get up and go. You have to ask for permission for going to the restroom, okay? For a child with FASD, if you do not tell or put this as a rule, put a visual around it, then children with FASD will not remember this rule. Therefore, making the rules explicit, meaning that showing them as like a on a poster, having them, giving them a piece of paper where the rules are listed, where it's paired with visuals, it's going to be really helpful. Another helpful strategy in education intervention is breaking down verbal instructions into smaller steps. Individuals with FASD have a lot of difficulties with following directions, and they do one step and then they would not remember the next step. Therefore, breaking the information down into attainable, chunks is really helpful, okay? Because they do have language difficulties, they do have difficulties with following instructions, okay? And finally, visual cues aid to help and pair with the verbal instruction. So when we are giving verbal instruction, maybe you can print that information and put it in front of the child so the child can follow the worksheet while at the same time listen to you in the classroom. All of these strategies can also be implemented at home when you are working with your child who has FASD to help them navigate the information so that the information is not overwhelming. And some of the classroom modifications would be to minimize visual and auditory distractions. Kids with FASD have sensory overload. Sometimes they are very hypersensitive to the stimulus around them. So the less stimuli in the classroom, the better. Okay, so that's very important. Making clearly designated activity centers. So making sure that the child with FASD knows where to go, where they need to work. They shouldn't be just in a chaos. Chaos does not work well while educating students with FASD, okay? Using daily schedules that are easily visible. Child with FASD should know, just like any other children, but more importantly with a child with FASD, they should know their schedule and it should be visual, clear, they should have access to it. The materials that they're gonna work with at school, both at home, they should be all organized. So at home, you can do a study corner where you got each of the folders and then you got their pencils and pens and pencil sharpeners in one place. And then they could have their, either their laptop or whatever they're working on all in one place. And periodically going through maybe doing that organization together so that they can also learn to organize their workspace. Okay. But if not, doing it for them is also going to be helpful so they don't engage in that meltdown, because everything that's messy is not going to help. And visually highlighting important aspects of tasks. Highlighters are the best friends for teachers or parents who are working with their kids with FASD. Highlight in different colors what you want them to attend to. Okay, so that's going to be a very easy but a very powerful intervention. So in terms of mathematics training, one of the programs is called the MILE program. So this MILE program is a math intervention that has been tried out in 2007 to improve the math skills and the behavioral problems of children with FASD. They tested it out on 56 children between the ages 3 to 10, and they provided a math intervention. So what did that look like? They had 6 sessions of individual instruction. Okay, caregivers were trained on how to facilitate the learning readiness of their child and how to understand how their child learns math. It's not like teaching them math. It's more about how the caregiver understands how your child does math. Because when we are trying to help a child with FASD, when they start to break down and cry because it's too frustrating, it's too hard, then we need to know where exactly that they struggled in. Okay, so this program was really, really helpful for that in that sense, because then the parents were knowledgeable as to, oh no, now I know. It's when they get into the regrouping, that's difficult because it's too sensory loading, because when you regroup, you have to borrow and so forth. That's where they had a problem with. Okay, now I know how to help. Instead of saying, what happened? I don't know, this is too hard. Instead of this type of a conversation, then the parents could have a conversation. Oh, you were doing so well. Let me see which part was hard for you. I can see that the regrouping didn't go well. So let's focus on that. Okay. So what they found was that the math intervention group in math, and then of course they had a control group. That's why this is one of the evidence-based groups. They always, these treatments have always a control group, as opposed to the control group who just received psychoeducation about math skills. Okay, the math intervention group improved their math-related skills. Okay. And they also, the good thing is that they also maintained these improved math skills in 6 months. So what we can say is that these, treatments definitely work in the area of math, because math is a very specific disability in terms of children with FASD, that they experience high rates of math problems. Like dyscalculia, meaning that they have hard time learning the calculations, they have hard time doing the problems, because math is very sequential, right? It requires step by step. First you do this part, then you do this part. It's very easy for a child with FASD to get lost in that sequence if they cannot break it down into manageable chunks. Okay, again, I always repeat that because that's one of the questions that I get all the time when I talk about interventions is, we don't have access to these specific interventions. What can we do? We still want to work with and be helpful to our children. Well, some of these you can definitely, when you design a program, okay, and I'll talk about at the end, but making sure that you can integrate some part of that math training, okay, into your program, or maybe hire a tutor if there are means around it. Having the child work with a tutor specifically on math, because we know that this is a very specific area of impairment that we very commonly see in our children. All right, the next one that I'd like to talk about is cognitive control therapy. This was also one of the big five evidence-based ones that I have reviewed, which has an experimental group, a treatment group, and a control group. Okay, So let's see what's going on in this cognitive control, therapy. So in this model, what they did was they worked with the children for 1 hour a week for 10 months. That's a long time, you will say. And yes, it is, a very long time. It's almost like a year. Okay. So they first implemented this within the school setting. Okay. So they focused on the following areas that I talk about, but like, what did they want to do? What was their goal? The goal was teaching children strategies to facilitate their ability to acquire and organize information more effectively. And you would say like, well, why do we bother with this one? What gives? Well, we know that children with FASD have specific impairments in processing information and integrating information and organizing information. They can learn in small chunks, but they have tremendous difficulties with organizing the information. And at the end, they can get confused and they give up, they get frustrated, then they have a meltdown. Okay? It's not because they can't do it. It's more of the information processing just interfering with the skill. Okay? So, as a result of that, they looked at, of course, they measured their executive functioning skills, they measured their cognitive control, they measured their self-efficacy skills. As you can now hear, self-efficacy is now a big theme, because when children believe that they can't do it, it's relevant for any child, but more relevant for our children with FASD. If they don't believe that they can do it, they give up, they get frustrated, they have some disruptive behaviors, okay? They have a meltdown, and that's probably the end part that we see, but we need to understand what happens at the very beginning part of it, okay? So we wanted to improve their overall cognitive processing skills as to how they even approach information, okay? So what are some of the things that they worked on? They worked on 5 areas. One is body position, movements, and self-awareness. Some of you maybe are here occupational therapists, so you would appreciate some of these interventions, such that they actually worked also with occupational therapists to teach children body awareness. Where does my body start? Where does my body end? If I do this, who do I hit? When I want to learn something, when I'm working on a project, what do I do? Do I have 5 things around me, or do I first organize my space? Okay, do I do my work like this, or do I just focus and look at my work? So these are all body positions, movements, things that we kind of like get ourselves ready. For example, every time, I get ready for a webinar, I see, right now I don't see how I look, but I see my slides. I kind of like check how I look. I position myself. I make sure that I'm not too tall or too, short on here. So these are my body positions, my movements, and my own body awareness that I'm actually seeing in the screen, and that actually there is not something weird at the background and things like that. So this is an important skill in learning. This is how we approach learning, okay? The next thing is, once we situate ourselves, what's the next thing we do? We scan our environment and we take the things that we need. Well, maybe to listen to the webinar today, you try to find your notepad to take notes or things like that, or got your slides up. That's called focal attention. So children with FASD have a lot of attentional issues. We know that. So teaching them specific scanning information and prioritizing, they get distracted very easily. So there is specific instruction on, this is not important right now. We're gonna leave that. Let's look at here. No, that part is not important. We're not gonna do that today. So when you start studying, all we need is your pencils, your notebook, and your book. Everything else can wait. Let's focus on here. Okay, so how do we prioritize information and then just disregard the distracting stimuli around us? Okay, that's very important. And then the next is processing information in the presence of distracting stimuli. Now we do some experiments, like we put things around them to see if they're going to be distracted, and then help them how not to be distracted. And then they also worked on controlling external information and categorizing information. So let's say now that we told them a story, and then in that story we talked about a history of something about United States, okay, a specific knowledge. So then we can say, okay, now that you learned about a little bit about the Constitution and only one part of it, so where do you think this information belongs? How is it related to other things that you have learned? So normally, typically, students do these themselves. We don't really go ahead and teach them these skills. So all in all, what I'm trying to say is that making the learning process very explicit. Again, you're hearing the same things over and over again. Making it explicit, okay? Making it like taking it out from the head to outside, okay? So it's that metacognition piece. It's like, how do we know what we do? Okay, so if I ask you a question, how do you learn? It's exactly the same thing. And you could say, well, I listen. I like to see the slides up. Then I take some notes. If there are things that are not clear, I ask questions. And then when I'm done with the webinar, I kind of save it along to other webinars. Maybe I have all these different tabs and categories. I put the information there for future referral, future reference. And then when it's time to use this information, because I had a client like that, I'll take that information out and use it. Well, that's the sequence of your learning process. That's your metacognitive thinking. Children with FASD do not have this type of process readily. Okay, so that's why we need to make this process explicit. And cognitive control therapy is one therapy that makes this process very explicit and teaches them these skills. Okay, so what happened at the end? The results was that they increased their self-efficacy skills. So the meaning that they now believe in themselves that they can learn, which is very important. They increased their motivation to learn. They increased their self-confidence. It increased their classroom behavior because now they didn't have as many meltdowns. They didn't have these throwing things on the desk. They didn't have these behaviors of throwing the desks because they were so frustrated. It also improved their general achievement skills, writing and communication skills. Okay, then you might say like, wow, that's an excellent one. Well, they also did some measures on how their overall executive functioning skills, whether they changed or not, okay, by using neuropsychological measures, okay. And in these neuropsychological measures, they didn't see a whole lot of change. So what does this tell us? I want you to think for a second. Well, it tells us that these interventions are effective and they're going to have benefit. But to show that gain in a neuropsychological test, the gains have to be so big. So the gains that we will have in providing these interventions to our children with FASD, they are going to be slow. We have to be patient. It has to span over a period of time, and the interventions need to be consistent. We can't just do it once and then, oh, you've learned it. That's not even possible for any child who's struggling emotionally, behaviorally, and so forth, right? So they need some more consistent support. But our children with FASD even needed more during the life course of their time. Okay, so it doesn't mean that these are not effective. It means that the gains that are made are slow. Okay, because brain is plastic. Brain will learn new skills, new knowledge. However, for it to integrate, it's going to take time. So we have to be just patient with some of these outcomes. And before the break, just check the time. The last piece I'd like to talk about is working memory strategies. So in the working memory strategies is such that children with FASD, we know that they have a lot of working memory deficits. What's working memory? So if I told you a kind of like a number like 1, 9, 4, 6, 7. Okay, so if I ask you to repeat this, what would you say? Would you be able to remember? Okay, so this is our short-term memory. So for working memory, now I'm going to say give you another direction. So I'm going to read you the same line of numbers, but this time I want you to tell them to me in the order going from low to high. So if I say 1, 3, 3, 1, what are you going to say? You're going to say 1, 3. Okay, so now I'm giving you a rule to operate from. So now you not only have to attend to it, which is short-term memory, now you have to do something with that information in your head before your response. So that's called working memory. So now I'm going to read you the same line and ask you to do it. So please put them in order from the lowest number to the highest number. Okay, 1, 9, 4, 6, 7. So hopefully you were all able to say mostly like 1, 4, 6, 7, 9. So we not only remember the numbers, but we also order them. So this is called working memory. So this is a specific deficit in children with FASD, unfortunately, due to the impact on the frontal lobe, where all of this working memory is housed. So what they did was they taught a simple rehearsal strategy to improve their working memory skills. Because I'm not sure what you did. What kind of strategy did you use while trying to remember the numbers? Well, one strategy was that they told the children to whisper the items after they were given. Okay, so they gave a list of items to the child and asked them to recall the items at a later time. Okay, this was done with 33 children who had FASD. The age ranges were 4 to 11, and they taught these rehearsal strategies to improve our attentional control and our memory. And what they found was that they improved on these scores when they did this task later, once they used the rehearsal strategy. And also it generalized, and that they used the rehearsal strategies also more later in other areas. So
how long can age hold the thing together? 17 years.
Oh, I think I hear some.
Let me try to find out who that is, Dr. Irving.
Okay. Can you all mute yourselves? I'll do a break right now. So I just wanted to finalize this part and make sure I get it all in. So these are some of the working memory strategies. So all in all, what we can say is that rehearsal is the key. Rehearsal when they are learning new information, rehearsal when we want them to repeat things. Practicing rehearsal is a very powerful strategy when we are working with children with FASD. Okay, so looking at the clock, it's 2:30. So we'll take a 10-minute break, and we would like to come back at 2:40 sharp because I've got lots of other nice information that I'd like to share with you today.
Can you hear me, Dr. Ergen? Can you hear me?
Yes, I can.
Okay, great. Just wanted to make sure. I don't know how people keep getting unmuted. That's strange, but
That's all right.
we're going to go to the questions when we get back.
Yeah, I think before again I transition, that would be good. And
Okay.
I think it's 2:40.
It's
So
already?
yeah, it's 2:40.
Okay.
So welcome back, everyone. Hope you were able to stretch, get coffee, take a little bit of a break. So I'd like to stop right now a little bit before I move on to some of the other interventions to get some questions along the way.
Okay.
Comments?
Suzanne Hartsworm is asking, what about effective treatments for 14 to 20-year-olds?
That's a great question. That is the more of the difficulty with these programs, such that you have all heard me talk about the age ranges, and that's why I specifically wanted to give you all that information. A lot of them start around like this, 4 to 12, 6 to 12, 5 to 10. So a lot of these really focus on younger children or just children of school age. There is not really a lot that is catered towards the kind of like the teens or the kind of like the young adults. I'll talk about 2 models for adults, not just the ones in kind of like between. So unfortunately for that age specifically, or you also haven't heard me talk anything about really 0 to 3, right? So we do not have evidence-based interventions at this time for FAST for infants and toddlers, okay? And then also for older teens. We have a couple for adults, but those are really the areas that the, researchers or clinicians really need to focus on to develop these and to pilot them and then to test them out. So then you might say like, okay, then what do we do? Are we going to treat them? Are we going to provide supports and so forth? So what I can say is that all of the things that I'm talking about, the elements of it, the important parts of it, they can all be also still implemented. We can always provide parent training, even for a 14-year-old, okay, to the parent. We can provide some neurocognitive training to the teen, okay. We can support and help them with the math instruction. We can still provide them safety skills. Again, all in all, from the research perspective, we wouldn't know if they are specifically effective for that age or not unless there is research around it. But it shouldn't really stop us from kind of like implementing some aspects of these interventions that I'm reviewing today. But research-wise, unfortunately, we are not there, and we have that gap in between, and we have a lot more things for that preschool to school age. That's a great point. Thanks for raising that.
The next question is from Ariana Brooks, and she's asking, what is the age range for cognitive control therapy? Okay,
again, let me go back to that one. It's not on the top of my head because there are a lot of them. The cognitive control therapy, okay, I do not have that information, but if you wouldn't mind sending me an email, I'll go back to that and I'll take a note of that one with the age range for CCT. And I'm happy to share that information. I just did not put that in there. Therefore, I would know on the top of my head. But I also don't doubt that it's similar age ranges that I've been talking about. But please email me and I'm happy to share that information and actually the article there too with you if you'd like, if you're interested.
Okay, that concludes the questions we have so far.
Okay, thank you. So I will now move on with the neurocognitive habilitation program and review some others there. So let's see. So this program was developed and piloted actually in 2012 by Dr. Wells and Dr. Chasnov. Some of you have participated in trainings that Dr. Chasnov has provided, so he must have probably talked about this intervention as being one of the tried 5 interventions that I've mentioned at the very beginning of my presentation. They tested this one out for 40 children who had various diagnoses under FASD, such as FAS, but also RAND. So which was also nice to see that children from the milder severity were also included. These were mostly foster children, and the age range, this one I included 6 to 11. So again, that school age range. There was a treatment group and there was a control group. Okay, so both of the groups received psychoeducation, but then the treatment group received the neurocognitive habilitation. Okay, so the treatment was first providing psychoeducation to the parents, and what they really focused on was recognizing the child's arousal levels, meaning that when is my child overstimulated? When does my child have a meltdown? At one point, what happens in their body? Okay, and by recognizing these changes in the child's arousal, then they can help to calm them down. Okay, they also taught these skills, of course, to the children themselves, such that the children learn when they are high level of alert, when they are normal and calm, or when they are not aroused enough, so they're not ready to maybe learn. So those were taught to the children, and as a result of that, when you are more aware, that self-awareness brings in responses such that you will now be able to be ready to learn, or you will now get ready to settle down. Okay, so this was a 12-week curriculum, and this was based on the ALERT program, which is a program that is utilized with traumatized children to work on self-regulation skills. Each session was 75 minutes. So now let's see what some of the results were. So all in all, to reiterate the goal was to improve, of course, self-awareness, executive functioning skills, emotional regulation, self-regulation, self-monitoring. Are we aware of our behaviors? Are we aware of ourselves? And ultimately improve memory and understand cause and effect. Like if I'm breathing really fast, the child will now learn that this means I am anxious, or this means I'm anxious and frustrated. And I know that when I'm anxious and frustrated, I lash out. So just combining these cause and effect pieces together, which, we know that children with FASD do struggle with cause and effect relationships and learning those associations. So this is all about strengthening the associations in the brain. So as a result, what they found was that there was a significant improvement in the treatment group, okay, who received this habilitation program over the control group in terms of improving their executive functioning skills as well as problem solving skills. So this was a very successful program in that sense. So I just wanted to put, and again, for those of you who are interested, I'm happy to send the article, which has examples of all of the sessions. So actually that could give you really, again, it's not the whole protocol. To learn this and implement this, you have to get the training from the research triangle from Dr. Chasnov's research group. They do work with organizations to provide training on this session, and after that they give all of the materials after the training. But in the article that they published, there are all of the examples of each of the sessions, just like the one I'm sharing right now. So again, if you're interested in this program, I'd be happy to share that article with you. So what do they do with the child? This is session 2. The child learns self-regulation. They learn about feelings and behaviors. So it's a group format. They learn to identify when their engine is running low, just right, or at a high gear, okay? The group leaders reinforce the idea that sometimes they need to adjust the engine because the engine is not working really well. And sometimes they need to be lower than it is, sometimes they need to be at a high gear. So they use a lot of analogies to make it more explicit. And we know that kids with FASD have more hard time with abstraction. That's another reason regular talk therapies would not work with kids with FASD, because they contain a lot of abstract ideas that the kids have hard time breaking down. So while children learn that, there is a concurrent parent session, and then the parents learn through PowerPoint slides with the group leaders about the impact of prenatal alcohol exposure, how it impacts the brain. They have some brain slides. They learn about behavioral dysregulation, how children with FASD prenatally, why they are behaviorally dysregulated, what's the system that gets impacted, so that they can actually now appreciate their children, they can understand their children in a different light. Okay, so I think this is a very nice program and an intervention where you work both with the child and you give information to the parent, and then you kind of like put all of those together so that children all in all learn good self-regulation skills. Self-regulation is very important, and I'll talk a little bit later on some examples of self-regulation activities, because you might say, like, how do we go ahead and do that? It's not too different probably from some of the self-regulation activities that you utilize in your own sessions when you're working with maybe traumatized children, or when you're working with kids who have more regulation issues due to maybe changing homes and things like that. So this was a successful intervention as well. So this one I'm going to touch base a little bit, because again, I'm not a psychiatrist, I'm not a medical doctor, but I reviewed some of that literature for you to share a little bit of this, information. So what was found and indicated was that, well, I wanted to share the statistics a little bit regarding pharmacological treatments. First of all, kids with FASD get prescribed high level of medication. Okay, so they did a research to look at the differences between kids with FASD and then kids who had psychiatric conditions. Remember, psychiatric conditions means mania, bipolar, schizophrenia, and so forth, right? Those are highly, they're more severe mental health. When they compared, they found that kids with FASD get, on average, 2.56 medications, compared to the psychiatric kids population who received 1.68. Okay, so that means that even compared to, let alone not other populations, but even compared to the psychiatric population of children, kids with FASD get prescribed such high level of or number of medication. I have clinically seen this when I received referrals for children for diagnostic clarification, and by the time they came to see me, they were already on 4 medications, sometimes 5. I've even seen 6. And we had to work with the psychiatrist to titrate some of them down and to moderate the situation. So then you might say, why are they on so many medications? Well, first of all, they don't get the right diagnosis, so they get thrown these different medications because the people think they might have bipolar, pediatric bipolar, they might have autism and other things, so they try to treat it wrong with specific medications. That's one. 2, children with FASD, they respond less favorably to typical medications, okay, psychotropic medications. Therefore, what happens is that because of their brain structure and that they do respond differently and less to typical psychotropic medication, what happens? They go to the psychiatrist and say, the psychiatrist asks, so how is John doing with the new medication? Nothing has changed. So what does the doctor do? Okay, let's increase the dose. They increase the dose, they send them back, and then they come back to monitor again. So they keep prescribing higher and higher doses, or adding another medication in the hopes that it's going to work. So they do a lot of trial and error, okay? I did not include this in my presentation, but there was some research and some presentation before where a researcher and a doctor came out with a diagnostic, like an algorithm for how to prescribe medication, psychotropic medication to children with FASD if they also have comorbid disorders. Okay, if anyone again is interested, I'm happy to. I know it's somewhere in my records, but again, it's very medication oriented. I did not include it here, but I'm happy to also share that, because that could also be a nice way to advocate for your children when you visit the psychiatrist to prevent from this to happen. Okay, so that's one point. The second one is around neuroleptics. So neuroleptics are our antipsychotic medication, right? So what we know is that the antipsychotic medications, especially risperidone, is highly used in our population with FASD to treat for aggression. It's also used very highly for treating kids with ASD, with autism. So overall, neuroleptics were found to be effective in the area of self-control, so to increase self-control, decrease aggression, increase problem solving in the parent and teacher reports. However, having said that, there has to be a very cautious approach there too, because I've also seen kids be on couple, sometimes 3, neuroleptics all at the same time, which, you know, they thought they had to also stabilize mood. They put a mood stabilizer, then there was a stimulant and other things. So it becomes a really a mess situation. Okay. What about stimulants? Because 70% of our children with FASD are diagnosed with ADHD, right? So use of stimulants is also very common, and they're prescribed very high level of stimulants. So I looked at the current research, and what it says currently is that stimulants are effective if the right one is found. And just know that it will take more trials to find the right stimulant for a child with FASD than for a child with only ADHD. Okay, that's why, again, we need more trials and more trying to find the best fit for the child. But when we do, or when the psychiatrist does, then it helps to decrease hyperactive symptoms. So with the use of stimulants, if it's the right one, hyperactivity was found to decrease. On the other hand, what it didn't help out with is impulsivity and inattention. So even through the use of stimulants, the kids' impulsivity level didn't change, or their inattention didn't change. They continue to have attention-based problems. So then what we can say is that if a child has a comorbid ADHD and high level of hyperactivity, the right stimulant might help. However, then we'll have to use some kind of cognitive, rehabilitation models that I've talked about, or interventions, okay, to address the attentional piece, because attention is not going to be taken care of with specific stimulant or medication. Okay. And then the last piece I wanted to touch base, because it's more up in the hot topic, is the use of choline as a supplement. Okay. So for this one, there has been some initial research around 2017 and then 2013 using choline as a supplement. So this is like a vitamin B supplement. It's similar to that. It's something that's found in fish, nuts, beans, vegetables, eggs, and it's supposed to help with things like memory, attention, and so forth. So Dr. Wozniak, who is a neuropsychologist at the University of Minnesota Medical School at the Child Psychiatry Department, and does evaluations for FASD as well. And I know so well because he was my supervisor when I was at the medical school for my residency. And I did FASD evaluations with him, so I'm happy to share his research too. So he did a double-blind, randomized, placebo-controlled study in 2013 with 20 children with ages, and I'll get your attention to the age range. We'll talk about that, 2.5 to 4.9, so 2 to 5 age range, okay? Of giving a dose of 500 milligram choline for 9 months, okay? So the initial pilot study was to see if they can even tolerate it, if there are any side effects of it, is it a feasible thing to give this to children, okay? What they found was that there were no adverse effects, no side effects, and it was tolerable. That's what they found. Okay? But what they found was that this was not the case for 5 to 10-year-olds. So they suggested that there is a critical time for the brain to absorb the choline, and that's more around that 4 to 5, age range. So then they went on and they did a 4-year follow-up of all of the children who used this, and then they, after that 4 years, they measured their IQ, memory, executive functions, and behavioral issues with 31 of those children. Okay, so what they found overall, and they all received obviously choline. So what they found was that there were increases in verbal IQ, okay, compared to the baseline. They improved their visual spatial skills, which we know is an area that they have impairments in. They increased their working memory. Remember, we talked about working memory issues. Increased their verbal memory, and they showed less behavioral issues. Okay. However, it was not helpful to improve executive functioning skills, visual memory, or verbal IQ. Okay. So we have some split, results in terms of which areas it was found to be helpful. Okay. So all in all, what they suggested is that if parents would like to do that, and then if the doctors are okay with that too, that they for that younger ages, okay, of course with doctor's approval, they can use it as a supplement. This is by no means a cure. This is by no means to get rid of all of the symptoms of FASD. So they didn't want this to be considered like a drug or medication, because it's not. It's a supplement. It's a vitamin supplement. However, it has some promising results that was also substantiated with children with FASD. All right, so having talked about that, now we've been focusing a lot about primary disabilities, right? Primary disabilities are the areas where the brain functioning is impaired in terms of memory. We talked about memory strategies, social skills, adaptive skills, cognitive skills, all of those pieces. But it doesn't stop here for our primary disabilities. Individuals with FASD also struggle with what we call secondary disabilities. Okay, up to 70% of the individuals with FASD, as they move on, as they become older, they tend to get these secondary disabilities, which are difficulties that arise as a result of the primary disabilities. Okay, so wanted to kind of like talk about what each of these are. First of all, how do we treat those? Okay. First of all, again, a lot of individuals with FASD, up to 80%, do have co-occurring mental health problems. So there is a lot of psychiatric comorbidity. 23% do have one suicide attempt. There is a lot of suicidal ideation. There is a lot of depression, anxiety, and so forth. So definitely there has to be case management, referral process in place if you are working with an individual with FASD, especially after they hit the teenage years. This has to be in our radar. Even if we are not the ones maybe to do it, we need to refer. If you are the case manager, if you are the social worker today, working with this population, hopefully this is in your radar to screen for psychiatric issues and then refer out for treatment as necessary. This is extremely important. Another one is substance use and alcohol use problems. Individuals with FASD are at high risk to develop substance use and alcohol problems. So there has to be a good psychoeducation and a lot of coping skills to avoid to use, and some alternatives to replace that impulsive, urges, and kind of work around this issue. And if it's identified, we need to screen for substance use for our teens with FASD, sometimes among the scheme of everything else that gets on the side. Okay. Another one is sexuality. So many children with FASD, when they become teens, they end up getting into trouble with the law just because of this area. This is an extremely important area. 48% of the individuals, teens with FASD, and then adults with FASD, engage in inappropriate sexual behavior, such as promiscuity, inappropriate sexual advances, because they cannot do the cause and effect. Like if I touch someone because, I just wanted to say like, there was one example from not an FASD client, but a client with autism. A young gentleman wanted to say, oh, you're developing nicely, and then just did this to a girlfriend's, chest area. So just putting the hand saying like, yeah, you're developing. They did not have any bad intentions. However, not knowing that when you touch and do that, this is not appropriate, okay? So sexuality training and providing information on sexuality and sexual education is extremely important to talk about safe sex, contraception, boundaries, and these would prevent unplanned pregnancies, which would further could become alcohol exposed, obviously. And then it would prevent also STDs, as well as it could prevent sexual assaults. There are some adults or teens who are serving because they engaged in these sexual assaults and they didn't mean to, they weren't maybe aware, but all in all, at the end, they do. And they have to live and experience, unfortunately, those consequences. So therefore, I would definitely suggest that if you're working with a teen, maybe one of our audience who asked about that 14, to 20 range, please, try to integrate all of these areas, maybe consulting with the caseworkers and so forth, to make sure to include these factors into the treatment. Legal problems, again, 70% of the individuals with FASD end up having trouble with the law. They are very vulnerable to confess crimes, things that they have not engaged into. They may not understand their legal rights when they are arrested. Therefore, as advocacy, we as clinicians, providers, and all the parents and caregivers, we have a big role in terms of advocacy within the legal system, okay? And I think that we also owe it to the legal system to provide them psychoeducation regard what is FASD. If you are arresting a child with or a teen with FASD, what should you consider? How should you, interact with them, okay? So we should do a lot of that consultation, advocacy to judges, law enforcement, public defenders, attorneys, probation officers. I've done, in my first years in this area, I've done a lot of training for in Montgomery County, and that's where I am, to judges, to public defenders, and then to probation officers, just to explain them what are some of the considerations that you need to engage in if you are interacting with a teen or an adult with FASD. That's where the advocacy piece really comes in. And then the last piece is medical issues. We know that there are a lot of birth defects also related to FASD, and some individuals with FASD are more prone to cardiac issues, dental issues, and therefore they need a lot of access to medical care, and they need a lot of follow-up. So with their primary disabilities, they may not be in the best position to advocate for their medical needs. They may not even locate those medical issues or be aware of those medical issues. So the caseworkers, social workers, caregivers, I think it should be a joint effort to advocate so that they have access to good medical care, just knowing that they could have heightened medical needs based on some of those impact of the birth defect. So in the area of intervention, what are some of our needs and what are the next steps? Well, first of all, a lot of things happen because we are not identifying early enough. The average age of diagnosis, and I talked about this in my previous webinars, I want you to kind of think as to kind of like have a number in your mind. What will be the age of diagnosis for a child with FASD? What's the mean age? The age is 9.5. It's almost 10 years. It's late. We have missed the opportunity for that brain development, plasticity, early interventions, using of a lot of the programs that I just talked about. They're mostly 4 to 11. By the time we have them, we have this so little window of opportunity. So better screening, better identification, better diagnostic models, and better services for diagnosis. That's definitely for sure. Then addressing primary deficits and not forgetting the secondary deficits that I just mentioned. Okay, dealing with stigma. Again, on my last presentation in June, I'll have a whole 3 hours talking about stigma and some diversity variables as it relates to FASD. So how do we work with the biological mothers, okay, regarding stigma? How do we work with the adoptive parents so that they understand and deal with the stigma? But if you don't call it like stigma training, we can just say, open up please the conversations. Ask your parents, ask the parents that you're working with. Okay, if you are a parent, if you're in a parent group, ask each other please as to how are you dealing with the stigma? What did you do? When did you tell your child what happened? Or when somebody said this to you, what did you do? What did you say? So opening up that conversation around stigma needs to be part of the intervention. We need to involve multiple systems. This is not something that one therapist and a client can do. This is not possible. This is not one of those disorders that we can just work in silo. We have to involve the system. We have to involve the school, the legal system, if it's involved already, the foster care system, the medical system, which is the psychiatry and so forth. So lots of systems needs to be in place. We need to have access to services to mothers who are continuing to use, so that the environment that they provide for their children hopefully will change. Because again, which I'll talk about next, is we need to modify the environment, okay? And then we need to have these treatments make more available to community-based treatments and engage in some of these efforts and advocacy as to why don't we have interventions for that adolescent to young adult age? Why don't we have any treatments right now that are validated for the infancy and toddler range? What if they're identified really early? Do we just do early interventions and call it a day? So why aren't we there? And what about for autism, which is also prevalent, but we have all the interventions in the world for all of the age ranges. So why are we lagging behind in this area while this is so prevalent with a 2 to 5%? So I'll talk about a couple adult treatments. So the first one is Parent-Child Assistance Program for adults with FASD. This was put together by Grant in 2004. And so what they did was that they worked with adults, okay, who had elevated rates of substance use, and they adults who had FASD, and these were all women. So this is more specifically, of course, for women, and they adapted it to use with women. So this targets women with FASD who are at risk of giving birth to children with FASD. It could be because they already have a child with FASD, or they are currently using, so they might be at risk. So this was a 3-year program where case managers worked with the women with FASD to increase their access to community supports. They ensured that their health needs were met, that they had access to safe housing, and then the case managers educated and consulted with the service providers, saying that this is what the needs are, this is what FASD, and so forth. So they tested this with 19 women. Again, I'll take your attention to the low sample sizes, okay? The age range of the mothers were 14 to 36, as you can see, young and childbearing age. So what they found was that after this program that they implemented, the women had increased secure and stable housing. So housing was very much nicely impacted. They decreased all alcohol and drug dependency. They started using more contraceptives. They started using more community resources, and they received more treatment for medical and mental health issues. So this was really a success to get them moving to where they needed to go and then to have a successful life. So in that sense, I would say this is more of a case management model. For those of you maybe in social work, caseworkers, working with mothers, working with women, could definitely be interested in this treatment. The next one that's more validated is called the step-by-step program. This is another one for adults with FASD. It's kind of a spin-off from the PCAP program. And this was tested with 24 women within the ages of 19 to 47. So the age range was a little bigger by Denise et al. In 2011. And they provided support to parents with FASD, okay? So there was a one-to-one mentorship for 3 years, and I'll get your attention. These are long-term engagements, okay? Following the birth of their child with FASD. So now this one is different because this time they are more identified. They are the mothers who already have a child with FASD, and then really providing all of the supports after the birth of the child, which I think is wonderful. So they provided housing, food, access to diagnostic services, and different community links, okay? And what they found was that the results showed that there was a reduction in the needs that the mothers had. And what were those needs? Family and parenting skills, positive, relationships with, other family members, and then, decrease in the behavioral problems of their children. Okay, so the largest gains were made in decreasing of social problems, increasing in housing and transportation, decreasing in abuse of alcohol and substances. Okay, the area that showed the least improvement was in parenting skills. And again, if you were interacting, I would ask why. I think it's pretty out there. This is more of a wraparound like case management. They did not do anything on specifically teaching, just like our other programs like the Pcit and the Families Moving Forward and other programs where you actually teach the parents the skills to handle the behaviors. Okay, so this is more for making sure that their lives are going to be consistent and not chaotic, and they will have all the supports that they need as they raise a child with FASD. Okay, so these are they're the very few treatments that are out there that are catered more towards adults. In terms of Petrenko came up with this lived experience model. He's the only one who did a qualitative research. Qualitative research meaning asking lots of parents about their experiences, their lived experiences, which I thought was really cool. And they did focus groups and they identified some themes. And the lived experience model indicates that there is, the parents think that the diagnosis is delayed, which we know, that their children had hard time qualifying for services. Again, something that we know, right? If they do not have ID, if they do not have the full-on FAS, they probably won't be qualifying for a lot of services. And the services that they qualified were not readily available for them to start. And the services were on and off, they weren't consistent. And the providers, that was the number one thing. They said that all the providers, including therapists, counselors, speech language therapists, OT, psychiatrists, school, there was lack of knowledge of FASD. So really, this is what our parents are telling us, that they know much more than anyone else. They are the ones who are living it, and they want the rest of the professionals and the providers to close that gap in terms of knowledge. This is, very telling, and this is, I wanted to share this because this kind of like spoke to me, by heart. And then the last one that I reviewed was by Koriwaku in 2011, who came out with the Dynamic Interactive Framework. So what he found out was that any treatment, depending on whatever you choose, from all of the ones that I talked about today, what are the key elements that we need to be, focusing on? We need to make sure that they are individualized. Why? Not one child with FASD is the same as other. We cannot put everyone in this big category and say, yep, that is work for everyone. Yes, we can do a start, but we still have to individualize our treatment. 2, it has to involve a parent support. I think I've emphasized that enough that you'll hopefully appreciate, and we'll be able to integrate the parents into your treatment. It has to have a direct child treatment component. Remember the ones who only work with the parents for case management? What happened in those? We didn't see reduction in behavioral issues. So while we're working with the parents to get them connected with the community resources, we work with the child on decreasing problematic or disruptive behaviors, okay? The program, whatever you choose, again, has to involve self-regulation skills, teaching self-regulation skills. This is paramount. And then the rest of the webinar, I'll just talk about that. And then it has to involve, if needed, as needed, medication or any supplements that the doctors will approve of or will think are helpful or needed based on the needs of the child. So this is our dynamic interactive framework. I think if you kind of like follow that and maybe pick and choose which ones you can handle or which ones your organization, maybe you want to say that in my organization, I'd like to come up with a FASD informed treatment. Okay, wonderful. So you can take this model and say, okay, who's going to do the parent training? Who is going to do the casework piece of working with the mothers? Who are we gonna refer for psychiatry who's maybe better informed about FASD? Okay, so that's a doable model, and I think that's really important that we work to establish this dynamic interactive framework into our existing therapeutic models. So I'll stop here again because the next is I'd like to talk about some examples of how we can work with our children in the most important area that I'm sure a lot of you have experienced, which is the self-regulation skills. So I wanted to see if there were any questions.
We do have a couple, Dr. Ergin. The first one is coming from Dean Roloff. He asks, can gene testing assist with identifying appropriate stimulant medication?
That's a good question, and unfortunately, I do not have enough background on the medication piece to answer that question with certainty. I'm happy to find out. However, sometimes with some disorders, psychiatrists have suggested that to be done when children do not respond to medication well. So I've heard this done in autism. I haven't come across any research specifically for FASD. However, that can be, I think, a great conversation to have with your psychiatrist to see what the child's body is able to tolerate or break down or consume as a medication. As a matter of fact, one of my personal friends who has a son with, was an autistic son, who had really disruptive behaviors, aggression, self-regulation issues, and they couldn't find the right medication for him. So he had to be homeschooled. But all in all, over in time, the psychiatrist referred for genetic testing to find the right medication. After that, things were beautiful. They found the right medication because he was on so many different medications that didn't work well. So I don't see why, but again, without reading specific research, I would be very hesitant to say, yes, that can be done. So if you send me an email, I'm happy to look it up and see what has been done, because it's the more area of medication and psychiatry, and my area is more psychology. I don't do routine, research on that piece, but I'm happy to learn more for you.
Next question is there more current information than 2011 and 2009? That comes from Susan Hart.
Regarding the treatments, I believe. I think, let me kind of like look at, this is a 2014, there is 2011, this is 2020 regarding the Colin from Dr. Wozniak. And then some of the information around the medications were around 2017 and 18. And then, yeah, the neurocognitive rehabilitation was 2012. So I looked at the current treatments, and this is actually where we are regarding any adaptations or anything like that. There might be some that are being done right now that have not finalized. So, but right at this moment, this is where we are in terms of, research on this. After my, rigorous, literature search, I might have, maybe missed something that's out there that I've been, put there. But when I looked recently for this presentation regarding the more evidence-based ones to see if there was any other that was added to that mix, I didn't come across any new innovative approaches.
And that's it for the questions right now.
Thank you. All right, and then the last part of my presentation, I wanted to focus on teaching self-regulation skills. So I know that I gave you lots of information regarding research, effectiveness of treatments, what those treatments do like, how they were done, and which parts of the treatments do we need to focus on. So I thought for the last part of it that I could give some examples of some self-regulation skills, so some things that we can actually apply. So what we know is that children with FASD prenatally, they get exposed to alcohol. And what happens is that alcohol impacts the midline of the brain, which is the hypothalamus, hippocampus, and it also impacts kind of like our frontal lobe and so forth, and many other areas. So while it does that, it actually disrupts the system where we respond to stress. So when we are encountered with a stressful stimuli, like we see a dog just kind of like running towards us, what happens is that our hypothalamus, which is the part that kind of regulates our behaviors, sends an alert chemical signals to adrenal glands to produce cortisol. Cortisol is our stress hormone. For fight or flight, it tells us, go run, or not run, but cortisol prepares the body for survival. It helps us store energy, and it gives energy to the muscles so we can run. It increases our blood pressure, blood flow. It constricts the blood flow to stop bleeding if we get hurt. It shuts down our digestive or reproductive system, so we don't even think about those. But while doing that, the negative part is that it reduces blood flow to the thinking brain, which is our frontal lobe. And our frontal lobe is our logical, rational part of the brain. And you know why it does that? Because it doesn't want us to think twice of running or not running. It tells us, you are in danger, go do something. That's why this part of the brain is shut down, okay? However, children with FASD, prenatally, this system gets disrupted with alcohol. Therefore, when they are born, the system of self-regulation is already impaired. And then on top of it, they also experience continued and complex trauma, most of them, because of their multiple placements alcohol and drug exposure in the home postnatally, and then continued neglected environments. So this leads them to have prolonged stress in their system. So the prolonged stress leads to continuous red alert. It's like red alert, red alert, red alert all the time. So think about our children with FASD to always live on that edge with that red alert and never having their system calm down. Okay, so there is a continuous production of cortisol, and that continuously shuts down the thinking brain. Okay, so as a result of this complex trauma and prolonged stress, their brains get wired structurally. Okay, and they start to store these signals and threats and terror and that helplessness. So anything that they see, regardless of it's threatening or not, is threatening to them. Anything that they hear loud, they might say, somebody's yelling at me. Well, maybe not. Maybe they're just talking loudly like I am right now. So their stress response changes forever. Every loud noise, every threat evokes that recollection that they are not safe. Okay? So as a result of this disruption, what we see is that children with FASD have poor emotional and behavioral dysregulation, and then which ends up in having emotional outbursts. So what can we do? We can't change the structure of the brain. We can't change the wiring of the brain totally, but we can create environments where they could feel safe and supported, where we can decrease the stress and teach them self-regulation skills. Okay, so I wanted to give that primer, and then I'm going to talk about what these safety skills are. So for safety skills, let's first kind of like talk about that. Children who had been exposed to trauma, and as I said, most of the kids with FASD do have postnatal trauma. They feel that when somebody's talking to them, they might be shamed, they might be punished, and they kind of like learn to engage in that negative self-talk. That's their default mode. Okay, so therefore, anytime they hear something loud and so forth, it turns off their higher order thinking, so they can't engage in proper behaviors to calm themselves down. So their emotional regulation system kind of like gets damaged. So that's why they need an adult to help them to regulate. Okay, so that's why we need a caring and a supportive adult. So when a child with FASD is overwhelmed, they are not capable of problem solving, they are not capable of engaging in goal-directed behaviors, they become impulsive, and they have a hard time controlling their bodies and their thoughts. Okay. Normally, typically, if they didn't have FASD, how do we learn self-regulation? Well, a baby cries, seeks comfort from mom or dad. They get the reassurance, a soft look, nice caring voice, holding, feeding them. That provides that safety. Okay. We rely on caring, supporting adults in our lives to overcome overwhelming situations. Think about ourselves right now. During the time of COVID, who did you rely on for emotional support? Did you have a caring, supportive, another adult in your life who maybe supported you with that? Because we all need that. So self-regulation is something that develops really early on in the 0 to 3 years. Then it gets refined and then sustained. It's internal and it's learned. Okay. So because their systems, they're born with more impaired self-regulatory systems, then what we can do is we can structure their environment, we can minimize their stressors, we can develop a warm and responsive relationship, and then we can help them to teach effective self-regulation skills. So what are those that we can teach? First one is affirmations. Affirmations are things like saying things like, I'm safe, I'm loved, I'm smart, I'm kind, I'm amazing, I'm important. So saying this to the children, and then they can learn to engage in these self-affirmations. Who doesn't need a self-affirmation to start the day, right? It's also found that those individuals who regardless of FASD or any other disorders, once people who start out with positive affirmations in their day, they tend to be better regulated. Okay. Kids often don't have words to say, kids with FASD. They have the memory stored on the right brain, which doesn't really talk with the left brain. So what happens is that when you ask them, why are you upset? They'll say, I don't know, I'm upset. I don't know, I'm angry, I'm frustrated. They don't have the words because that's kind of like they have learned that the adults in their lives are unresponsive. They're not going to provide them safety. They are to be feared and they cannot be trusted. So they engage in this defense and self-protection by saying no, and then just like, or by just engaging in a disruptive behavior. So that's why we know that due to this, they are not willfully defiant. They're just protecting themselves from danger because they do not feel safe. Okay? So how can we make them feel safe? Physical safety, where, let me see if I have a, no. Physical safety is when we make sure that they do not get abused further. They do not experience neglect or physical abuse. Okay, so that's why making sure that they have a safe and a reliable home before age 6 is extremely crucial. Socially, social safety. We can make sure that they do not get bullied. A lot of the kids with FASD experience bullying, okay? And then they get respected and they don't get any emotional abuse. Emotional safety. We have to make sure that they receive empathetic interactions, compassion, acceptance, and not being shamed for the behaviors that they engage in, which are not willful. And culturally, just making sure that they do not experience racial trauma, racial, cultural, ethnic discrimination. Okay, all of those will continue and perpetuate the cycle. We cannot break the cycle if we do not provide safety to a child. This is a very, in one hand, very easy intervention. In another hand, that could be, of course, difficult if the people around the children really are not providing these. Okay. So when these do happen, it all starts out with the adult. If the adult is self-regulated, it's kind of like contagious. They also regulate the child. Okay, if the adult is dysregulated, child is dysregulated. And therefore, they need to have an adult who is reliable, consistent, available, honest, and transparent. Okay, so those are really, really important things that just by providing this information to the parents who are caring for children with FASD, we can work on the safety skills. So how do we provide some of these interactions and connections? Okay. So some of the things that we can do is providing a good eye contact, a soft gaze, soothing talks, holding them, engaging in a kind of like a playful facial expression, avoiding eye gaze that's associated with pain and, you know, like a rejection, okay? Getting down at their level, offering them the eye contact. You can't really force the eye contact, right? If they're agitated and they don't want to have eye contact, stay parallel to them, so not face to face. Avoiding that overstimulation. Using a soft tone, a soothing voice, and not say something like, look at me. That won't work. Saying something like, let me see those beautiful eyes of yours. Okay, so kind of like very soft approach. Another one is present. Set aside time to spend time with the children with FASD and giving them the affirmation that you're valuable to me and I'm present in your presence. So not looking at the phone or trying to do other things, even though that's 10 minutes a day, okay? It gives the message that I like being with you. There is nothing more important than you. And visibility is very important. Kids with FASD are often invisible. That's why we call it invisible disability in many, many ways. So we want to make sure that we integrate this into any of our interventions where we talk with the parents that being present with them is extremely important and a very important intervention. So devoting our full attention with no interruption is the key. While doing this, we want to make sure to allow the child to take the lead, okay? Showing interest in their life, asking them and noticing them. No judgment, okay? No demands. We don't ask them to do things, okay? We just describe their efforts. For example, when you play with them for 10 minutes, you can say, perfect, you built a tower. We don't say like, can I help you, if they can't do it, okay? Or we can say, that wasn't, you couldn't really do that. So no judgments, no help. It's just being there and describing what they do. That's a very powerful intervention. So what that means is noticing connects us, judgment disconnects us. I like that because when we notice, even for our regular interactions, it creates that connection with other people. But when we start the conversation with judgment, it already puts a distance between us. The next thing that we can do is playful engagement. Okay, playful engagement is really it helps to release dopamine. So any kind of play, it helps to release endorphins, stimulates the growth of the neural pathways in the emotional regulation centers. That's why it's really important to play with children, especially when they're younger. It gives us a sense of euphoria. It builds trust, and that's something that kids with FASD need a lot, and they're devoid of it most of the time from their more painful background. It reduces the cortisol levels. And remember, when there is less cortisol in the system, what happens? It opens up the frontal lobe and has access to the frontal lobe to make better decisions, better regulation, less impulsivity. And everything becomes more positive and joyful. Another piece is healthy touch. Healthy touch is babies would die if they didn't experience any touch. Literally, they would not make it. So engaging in that healthy touch with the open hand touch as opposed to the fingertip touch. So something like a high five, a pat on the head, a handshake, bear hugs. Now, of course, with the COVID, we have our side hugs. A firm hug has a calming effect on the body. It again lowers the cortisol levels, slows the heart rate, lowers the blood pressure, produces all the good serotonin, and it also helps to decrease pain. It's already used in children who are going through painful procedures, is engaging in that hug and healthy touch. Okay, so what they found was that access to a healthy touch actually increased positive behaviors and decreased aggression. How this can be integrated in the schools or morning rituals is morning greetings, like you could do a fist bump, pat on the back, of course, always with permission. We have to respect boundaries. If a child is not willing to do it at the time, we let it go. Instead, then we can say, clap above your head. So instead of touching the head, then they do it themselves. Give your thumb a squeeze. So they do it and we do it too. We just mirror each other. Place your thumb inside your fist and squeeze tightly. Okay, so we can do activities like that if they are not willing to be touched, because some children will have more difficulties and more sensory difficulties with that. And then the last piece is we teach coping skills. So yes, we help them regulate, but we also have to teach them because they are born with some of those skills not there. So we have to make sure that we give those skills as well. The first one that I wanted to talk about is breathing. Again, these are all things that all of you probably have used and know and have learned about. So I'm just talking about these in the context of how it's helpful for FASD. For deep breathing, we engage in the belly breathing. We have to teach the children the difference between the belly breathing, like, we smell the flower and then we blow the pin, the wheel, like we blow a bubble. So we want the slow respiration. This gives the brain oxygen, puts pressure on our vagus nerve, and it helps us connect with the brainstem, so which signals the brain to shut down cortisol. It's all about shutting down that extra release of the cortisol, which will shut down the frontal lobe. Okay. It also reduces the heart rate and makes us more calm and relaxed. But if we don't do this, when children get frustrated, what do? They hyperventilate, right? This shallow breathing lowers the carbon monoxide in the blood, restricts the arteries, reduces the blood flow, and it prepares us for fight or flight. Like now we have to fight. Now they engage in fights and arguments and they start getting all physical, okay? That means no access to prefrontal cortex, which means higher irritability, higher impulsivity. So breathing definitely helps out with that. And I provided a handout for a progressive muscle relaxation. It's actually more geared towards, adults, but I think that's really helpful to use it with the parents. And any kind of progressive muscle relaxation. So it's not specific to FASD, obviously, but I just, wanted to do it actually if we had time, but I'll just kind of see about that. But if not, feel free to utilize it. Even if you do it for 5 minutes, it helps us to shut down the lower part of the brain and gives us access to the upper part of the brain. Sometimes we will need something extra like sensory motor interventions. Well, some of you might be occupational therapists and that's your area, so you go for it. But if you're not like me, and I know not a whole lot about sensory motor interventions, but what we know is that kids with FASD do have sensory overload. They get overstimulated very easily. So some kind of calming center would help, and things like a heavy blanket, stuffed animals, noise canceling earphones. I borrowed some things from my daughter. She let me do it. So some things like these, stress balls with the beads and things like that. These days, children are very much dying over these things that kind of like pop. I don't even know what they're called, but we have several of those in our home too. Or, you can have these like thinking putties. So any kinds of things that these sensory balls and things like that, fidgets, calming bottles, rocking chairs, swings. I think it's very helpful to create in the home and in the school some kind of calming center with a combination of these tools where we can just say that when they are overstimulated, it helps them to gain access and then to calm down. Of course, if there are further issues and difficulties, referral to an occupational therapist for an evaluation, which is their area, and for more specific interventions is also warranted. And then one of the last pieces is sensory self-reflection. Self-reflection is all about mindfulness, and I'm sure you've read, exposed, implemented a lot of mindfulness strategies. This is all about noticing the selves. So it primes our brain for self-regulation. Kids and kids with FASD can definitely be taught about self-reflection. Okay? So self-reflection is being present with ourselves. It's recognizing our own emotions, identifying our triggers, understanding our thoughts, emotions, and when they are there and how. Okay? And it provides us a choice of how we respond. Now, we are not just, or children are not just bound with impulsivity. They are not bound with frustration. They have other choices, okay? So then we could say, well, Dr. Argun, when they get in a rage, I cannot have them implement any of these pieces. You are true. You're true. Who as a parent has not been able to implement the strategies we all as clinicians have learned to your own child? I couldn't at certain points. So some things went wrong, obviously. So when a child is in a rage because of all the problems that we talked about, it makes us upset too. So the first step is being regulated ourselves, okay? And then what we can say is taking 3 breaths and noticing what's going on inside, okay? We can say things like, my heart rate is fast, my breathing is shallow, I also notice that I'm safe. So kind of like helping them to kind of like regulate. I've got this. This is going to pass. So kind of like writing them a scripture for when they can use, maybe after they kind of calm down, maybe sending them to the sensory area. Once they get a little bit calmed down, then you go and just you start practicing the breathing. Then you practice the self-reflection, okay? So while doing that, we need to use soft eyes, low tone, and non-threatening body language. Even angry eyes, like, there we go again, there's another tantrum. Kids will pick up on that. Kids with FASD are very sensitive. They're good with picking those pieces up because it's almost wired in their brain that there is a threat. And when they perceive it as a threat, they will react even more. Okay, so we'll do self-relaxation, using self-reflection, identifying the big feelings, acknowledgement, sense of safety, and saying that I'm safe. And then last, finishing with affirmation, affirming that they're competent to return to calm, saying like, I can handle this. Okay. And looking that I have 10 minutes, so I'll see what I can kind of like provide you with, like a summary. So we can integrate the self-regulation skills into our interventions. But all in all, I've talked about many disruptive problems and behavioral problems. So I wanted to give you also a sense and a summary. These are all things that I don't think, that are new, but you probably know already. But there are different types of behavioral problems, and our kids with FASD show all of them. Some behaviors are what we call over-controlled behaviors. Things like withdrawal, isolation, shyness, depression. So kids just control themselves too much, okay? We call them internalizing problems. Then we have under-controlled behaviors, which is lashing out, aggressive behaviors, disruptive behaviors. Some of them are, we call aggressive because they involve physicality, stealing, destroying, fighting, defiance, tantrums. The other one is overactive, which is more kids with ADHD. They don't destroy, they don't necessarily have tantrums or willfully defiant, but they cannot sit still, and they're quite impulsive, and sometimes that leads to issues. So our kids with FASD show both uncontrolled and over-controlled behaviors. So this is from Dr. Chasnov's new book, Guided Growth, 2020. He kind of listed very nicely the functions of behavior. So why do children engage in these disruptive behaviors? Well, we already know that they don't do it because they're bad or they're willfully doing it. Then how do we understand and change these triggers? So the motivation can be that they want to control the situation, which is fine because who doesn't like to be in control, right? They can maybe do it because they want to protect themselves, because they see this as a threat. They want to escape from there because it's too overstimulating. They want to avoid that situation, okay? Maybe they are wanting to get attention. That's only one of the hypotheses. Maybe they're just looking for acceptance and affiliation and acknowledgement. Maybe we're not providing them enough. Maybe they want to express themselves. They want to get a word. That's why I always said in the treatments, please involve the children's voices, okay? They want to express themselves. That's why they're interrupting all the time, maybe. Maybe they're not getting enough turn. They want gratification. Who doesn't want gratification? We're all about instant gratification, but we can't, okay? So what can we do? Can we maybe provide them more consistent gratification so that they're not after gratification all the time? And sometimes it can be a revenge or justice. Do they feel that they have been wronged? Some children feel that way. So then we provide interventions that is more catered towards that. And then I wanted to give some examples of behaviors and what message it gives. I'm going to read some of them. If we see a child who is not complying, and we see this probably quite a lot, right? What message does it give us? It might mean that this is too hard, I can't do this, or I don't know how to do this, okay? If they are aggressive, they might be maybe telling us, I don't think I'm being treated fairly, or I can't cope with this, lack of coping skills. If a child is withdrawing and shutting down, it might be that they're scared. Maybe they think nobody cares for them. Maybe they're just sad, okay? Maybe they don't know how to ask for help, okay? So we have to look at the function of the behavior. That's extremely important, is to understand the function of the behavior. Because only when we understand the function of the behavior, then we can start to provide interventions to replace that behavior with more effective behaviors. So they are not causing any problems for the child. So how do we do that? By using a problem-solving approach that probably all of you who've done behavioral therapy already has done this numerous times. But the main pieces in problem-solving approach is definitely first identifying the target behavior. What is a target behavior? Target behavior is an unwanted behavior that occurs repeatedly that needs to change or to be replaced because it's not serving a purpose, okay? It could be interrupting all the time. It could be making vocalizations and just yelling all the time. It could be hitting someone else, okay? So first, we have to identify it and then define it, what it is. I've heard a lot of parents say, so tell me the behavior that you'd like to change in your child. And they said, they're just annoying, very mischievous. That's weird behaviors. Well, we can't define them. What is weird? What is annoying? It just differs from person to person. So let's get down to it. So first we try to operationalize and understand what that behavior is. So we asked a parent, can you tell me more about the behavior? Like when you feel like your child is annoying, what kinds of things do they do? Well, they ignore my requests. I have to tell 50 times. Okay, I can write that down. Ignoring requests. That is the observable behavior that we can work with and replace. Okay, but we can't replace annoying specifically. They get up their seat. The teacher says that. Okay, we can observe that. We can deal with that. They cannot settle down. Yeah, we can deal with that. They are too loud, interrupting. We can deal with that. Okay, so to do that, first we have to collect that baseline data. We need to know how frequently it occurs, what's the severity, where does it occur, with whom it occurs, how long does it take, okay? If it's being loud, is it all throughout the class? Or is it like all night? Or is it just a couple hours a day? When? It's just more in the morning. They just cannot handle the morning. Now we're just seeing more patterns that there are more issues in the morning than evening time, okay? Integrate the distal and proximal factors. Proximal factors are things that have a direct relationship with the child, such as their developmental status, skill deficits, poor frustration tolerance, being overstimulated, classroom environments, medications. So we have to, when we are designing interventions, we have to take all of those into consideration. So before you even want to treat, I would say just for a good problem-solving approach, get all of this information about all the proximal factors, okay? Because then we can say, when he takes the medication, then he becomes, agitated this way. So what can we do during this time? Then we can try to maintain that behavior, okay? And the distal factors are things that are indirect, like financial issues, cultural issues, parental drug use. It's good to know about them. We might not change them. So just knowing that there are some things we can work with, some things we can't, but we sure can integrate it into our treatment. Then we need to take the parents as partners in the treatment. I think I have emphasized that pretty much along my presentation today. And while doing all that, we need to be respectful and non-judgmental. Parents are the best advocates and they know their children the best. So let's listen and let's take their word for it. And give the children also a turn to design their own interventions too. And then once we do all that, brainstorming all the possible interventions, and then saying to the child and the parent, this is what we came up with collaboratively all together. Let's implement it. And if it's not working, then we'll evaluate it and then we'll revise and come up with a different approach. So all in all, our goal will be to replace the target behavior, right? Because the behavior serves a function. But we can't replace all behaviors as some are unacceptable, for sure, right? So, for example, hitting. There is nothing in between. They just should not hit, right? So we have to have, what do we do then? We have to have clear rules for the unacceptable behavior. We say, you may not hit another child. You may not put others in danger, okay? and then you may not destroy property. And daily reminders for these are critical so that it gets kind of ingrained, okay? And if they get angry because we are reminding them the rules or they're engaging in disruptive behavior, the first thing we need to do is validate their feeling. How do we do that? In a calming voice, we say, I see that you're feeling angry, okay? Then second, set a limit, because we still have to set a limit. That's a behavioral part of it. We cannot hit our friends. Remember, we talked about that before. That's not acceptable. And then, we work to replace that. If they're really feeling angry and they need to, hit on something, so they can have some kind of like a punch pillow, stomping pad, or anything where they get the anger out, and then we can say, what else, can we do? How do we then calm them down? We can remove ourselves and them from the situation, go to a more calmer place. We can have them count to 10, have them close their eyes. That automatically calms a person, okay? Starting to do the deep breathing, listening to calming music, going to the soothing corner, and then, as I said, giving them something to get the anger out, could be some possible interventions. And then my last piece, which is really a summary, so I don't really need to go through all of that, but successful strategies that work with children with FASD uses concrete, direct, explicit instruction, okay? Lots of rehearsal, lots of practice, lots of repetition, consistent and specific and short directions, okay? Limiting stimulation to prevent the overload, constant supervision, concrete language and examples, and multisensory learning where they can integrate the information, realistic and helpful expectations, and a very supportive, stable, consistent adults and environments in their lives. All right, and then the rest you can just kind of like go through for some of the resources, and then ending out with my references. So I think I've made it to the 4 o'clock timeline. I know we have some extra time, I think probably around 10 minutes to make up for the break, where I can actually get questions and we can engage in a discussion as well. So wanted to see what questions there might have been for the last part that I talked about.
I don't have any questions quite yet. Okay, here come, no. No questions.
Or maybe any reflections, any feedback from some of your experiences for those of you who have provided some interventions to children with FASD, or how you are maybe planning to use this information to integrate into your treatments. Any kind of reflections would also be helpful.
Doesn't look like it. Okay. It's interesting to know how children with FASD cross over to other behaviors.
Exactly.
That was from our peer supporter, Kristen White. JJ Dunn, how to maintain consistent schooling within school shutdowns.
As far as that consistency piece, right? I talked a little bit about that in, I think, June. We did a presentation and talked about some of the COVID, how to manage things, during the COVID time and so forth. So I think what would be helpful is whatever they experience at school. Okay, so it would be good to have, hopefully a lot of the parents do know their children's schedule at school. But if not, you can contact a teacher to give you an exact replica of the schedule. Like, oh, at this time, that was their snack time. This was their transition time. This was when they did this class. So we could try to replicate exactly the same thing at home so that they don't feel like, I've experienced this in my child when we did the complete shutdown, and she said, this time was the snack time. So I said, okay, why don't we just pretend that it's exactly the same, and you can just go and get a snack. So again, I can tell that to her and she'll do it. But again, for our working with our kids with FASD, we come up with that exact same structure and plan, and then make it into a visual. So they exactly see it as the same as the classroom, and we can go ahead and implement that piece. Okay, so that's definitely one piece that I've seen and read about to maintain that consistency.
And the second part of his question is, am I better off homeschooling?
With instead of the on and off, right? That's a good point. Again, without knowing the specifics of your child and needs, it's hard to say a generic answer. But what I would say is, instead of I guess a back and forth, probably for children with higher needs, higher educational needs, and more consistency, homeschooling could prove to be better. However, then if you tell me that your child needs a lot of social interaction, because that's what you're working on, and they can't get that social interaction if it's online, then I would say maybe doing the face-to-face would be better. So again, I would happy to do a consultation, but just knowing not knowing the specifics of the child's needs, it's hard to give a blanket answer. But I would say for the educational piece and the consistency of it, continuing a consistent plan, either one way or another, would probably fare better, unless you have the information that things are going to open up and be like all face-to-face, which is hard to know these days.
Alva Pugh asked, where can we get more information about the intervention treatments?
I'm happy to send some articles. However, here is the piece. The articles only have information. They do not lay out, for example, like families moving forward protocol or neurorehabilitation program. Unless you go pay and get the training, they do not give you the exact like plans and all the worksheets and things like that. So unfortunately, we do not have access to that. But regarding learning about self-regulation skills, Dr. Chasnov has the new book called Guided Growth. I would really recommend it for either parents or educators or clinicians working with kids with FASD. And I got a lot of that information on the self-regulation piece. So there are actually really laid out sections where you can get more further information about how to design that self-regulation piece, with your children. So that I think would be a great guide. And if you'd like more specifics on the intervention programs, I'd be happy, if you email me, I'd be happy to send all of the articles or any of the articles that you are interested in through email. Here in my presentation, I did, of course, a summary of those, but they contain more detailed information. And even sometimes you can email the researcher, the person who designed that intervention, and maybe ask for some materials if they are willing to share with you.
We have a couple of comments. Patty Finch says, thank you. And this was very interesting and informative. Barbara Beal said, no question, but this is one of the best trainings I have sat in for children with FASE. I love the intervention treatments. This was an excellent training. Really needed this for the children we served. Great training.
Thank you very much. And thank you so much for serving our children with FASD. That's wonderful. And I hope you can find one or two things to integrate into your existing intervention models.
And that's it, Dr. Irving.
Okay. Well, thank you very much for all your interest, for signing up for this workshop and webinar. And as I said, you have my email at the beginning of the slides that you received today. Feel free to email me for further questions that you might not have thought about. access to some of the articles, the name of the books, or anything that I might not have shared here, I'm happy to consult or discuss or talk with you too further. Our next webinars are on how to navigate the school system once you have a diagnosis of FASD, advocacy in the schools, educational interventions for kids with FASD. And then my last one is going to be in June. You can find the specific dates, I think, on our website. And that's going to be on working around stigma models, and some diversity variables regarding FASD, which I think is extremely important, especially these days. So thank you for listening today.
And if Shar is still on the phone, do you have any reminders, Shar?
I'm still here. What do you want to know, Karen?
Do you just want to give them a fresh reminder about the evaluation?
If they have any questions or concerns, to feel free to follow up with the FASD general mailbox. They should receive their CE certificate within 7 business days. And that's really just about it. If they have any questions concerning CEs, they can feel free to give me a call. Or sorry, give me an email. Email me and I'll respond to them.
Yeah, you should receive your certificate in 7 days. I think
Yeah, within 7 business days. It just depends on once I go in and do the report for participation, how big the class size was.
And I put the email address to send your concerns in the questions box for your reference.
Okay.
So thank you all for attending. And we
you can and maybe, I don't know, you want to tell them when you're going to launch the May registration?
I'm probably going to do it Monday.
Okay.
I want to over with. Yeah. I want to get this over with, and I'll send out the save the date for them to get registered for this on Monday.
Okay.
Okay. Thank you, Shar.
All right. Thank you. All right. I'll see. Have a good weekend, guys.
You too.
Thank you for all your help. Thank you.
So goodbye, everyone. Thank you, Dr. Ergin.
Thank you. Are we gonna connect later or maybe another time?
Yeah, another time.
Okay. All right. So then I'll just log off.
We'll schedule something.
Okay. All right. I'll log off then for now. Okay.
Okay.
Thank you. Bye.